I request Amrish to introduce the moderator of the day, Dr. Rahul.
Yeah, thank you so much, Dr. Kalavani. I think we are very excited that this is the final session in the series of CAKUT today, and I have two of my close friends here conducting the session today. And first of all, let me introduce Dr. Rahul Chanchlani, and he's an associate professor in the Division of Pediatric Nephrology at WEBMASTER Children's Hospital, Hamilton, Canada. He is also the fellowship program director in Division of Pediatric Nephrology. And I can tell you that he's always looking for young minds to come over for fellowship. So people in the audience, do keep that in mind. He is a master in clinical epidemiology as well. And he's an associate faculty in the Department of Health and Research Methods in McMaster University. His special interests are ambulatory blood pressure monitoring, and he has published a lot of studies on that. And his clinical interest is also acute kidney injury. He is an active member of International Society of Nephrology and is a clinical research committee member. And he's also the board member of International Society of Nephrology, North America and the Caribbean Regional Board. He is also a recipient of the IPNA, International Pediatric Nephrology Association, Rena Habib Young Investigator Award. And he is also part of the Junior Empowerment and Mentorship in the IPNA program. He has multiple grants, and he's a very well-funded researcher, and he has multiple peer-reviewed publications. We are really excited to have Dr. Rahul here today. I'll hand over the session to you, Rahul. Thank you so much.
Thank you, Dr. Amrish Jain. Thank you, Dr. Kalavani Ganesan. I'm so excited to be here. Thanks for having me here. And thanks everyone for joining from wherever you are. So good morning, good afternoon, good evening. And it's my absolute pleasure to introduce Dr. Shaina Menon, who is an associate professor in the Division of Pediatric Nephrology and Department of Pediatrics at the Seattle Children's Hospital, University of Washington. She's also the medical director of acute renal therapies and the associate medical director of apheresis services at her center. Her clinical and research interests are in acute kidney injuries and specifically long-term outcomes after AKI and extracorporeal therapies, including CRT and plasma exchange. She has been quite productive, believe me, and she has multiple peer-reviewed publications in pediatric nephrology and other pediatric journals. Dr. Menon, thank you for joining at 6 in the morning and from Seattle. We are so eager to hear your talk on CAKUT and neonatal kidney failure. So over to you. And also feel free to put your question in the chat box. I will be monitoring all those questions, and we can have a question and answer session at the end.
Sorry to intervene. Dr. Namalwar also has joined the session.
Oh, sorry.
Like Dr. Sheena was asking about Dr. Namalwar.
I'm sorry I came late, ma. How are you, ma?
All good. So like.
Nice to meet you, Dr. Namalwar. We used to hear your lectures many years back when I was in India. That's good.
So thank you for remembering me. Thanks a lot, Dr. Rahul. I think we can start your presentation, ma.
Okay. Thank you, Dr. Namalwar. Thank you, Dr. Ganeshan and Dr. Jain and Dr. Chanchlani for the introduction. I'm going to share my slides here. So I hope you can see my screen. Thank you everyone for joining today. So I will be talking about severe CAKUT and neonatal kidney failure. These are my disclosures, and I will be discussing off-label or unapproved use of certain dialysis devices because that's how the world of pediatrics is. Not everything is always approved for the pediatric age groups. So over the next 45 minutes to an hour, I want to start by giving you a spectrum of some of the kind of cases I've come across with severe CAKUT, do a brief recap of what neonatal kidney physiology, especially in CAKUT, is, and then spend more time talking about management of patients with these conditions, whether that's prenatal management or postnatal management. So our case one is a 32-weeker neonate who had a birth weight of 1,500 grams. There's history of premature and prolonged rupture of membranes, and the baby was known to have bilateral fetal renal agenesis. Received multiple fetal amnio infusions during pregnancy. At delivery, after delivery, the APGARs were 1, 4, and 8. The baby is intubated, surfactant is given, and nephrology gets called to see this baby because of the known renal agenesis. A second case, different on the spectrum, is a 39-weeker male neonate with a birth weight of almost 3.5 kilos. The mother was known to have gestational diabetes, well controlled on glyburide. Prenatally, the diagnosis of left-sided multicystic dysplastic kidney was known. There was mild polyhydramnios prenatally. Postnatally, once the baby was born, MCDK was confirmed on the ultrasound on the left side. The right kidney looked healthy on the initial ultrasound. There was a serum creatinine done at 24 hours of life, which was 1. And then over the next 24 to 36 hours, there was a decrease in urine output. So a repeat set of labs was done, which showed a creatinine of 2.65. This baby had a renal ultrasound done, which showed that the left kidney looked dysplastic as it had before. The right kidney looked normal. The vessels, renal vein looked good on the left side, but on the right side, they could not get good images of the renal vein. So this baby progressively became anuric and was transferred to our center because of oligoanuria. His creatinine was 4.2 at the time. A repeat renal ultrasound was done where the main right renal artery was not visualized and there was no arterial flow within the renal parenchyma. A small renal vein extending from the hilum to the IVC was seen, which also showed no flow. No thrombus was noted, however. Interventional radiology did an arteriography in this baby, and they saw that the right renal artery was thrombosed, and they treated it with local thromboplastin or alteplase. There was some partial recanalization and perfusion of the vessels seen during this imaging process, and the baby was sent back to the NICU for follow-up. A third case is a baby, almost a full-term baby who was born with a birth weight of 2.5 kilos. Prenatally, there was a presumed diagnosis of autosomal recessive polycystic kidney disease with oligohydramnios at 32 weeks gestation who progressed to anhydramnios. This baby required intubation and high-flow oscillator ventilation for severe respiratory failure, had left-sided pneumothorax, had a chest tube placed, was fluid restricted initially, and then continued to progressively worsen, and had a high creatinine and severe oligoanuria subsequently. And a fourth baby is somebody who a full-term baby born at 3.5 kilo birth weight, had tight nuchal cord, had some meconium staining, had low APGARs at birth. Immediately post-birth was noted to have bilateral tension pneumothorax, received chest tubes placed, had to be cannulated for veno-arterial ECMO because he had persistent respiratory failure cyanosis. There was normal amniotic fluid noted on prenatal ultrasound, no mention of hydronephrosis, and postnatally saw that baby had bilateral severe hydroureteronephrosis. This baby had a father who had history of obstructive uropathy, status post valve ablation, and status post transplant, who was taken care of at our center. The baby had good urine output initially, but it kind of gradually decreased by day 3 of life and had fluid overload. And like the other previous 3 babies, this baby also required a renal replacement therapy. So it kind of shows you a spectrum of babies who can be born with severe CAKUT or severe congenital anomalies, and then go on to developing kidney failure in the neonatal phase and requiring renal replacement therapy. So with that, let's kind of look at just the overall spectrum of CAKUT here. So as you might remember, major developmental events in the formation of kidneys and urinary tract include the formation of the ureteric bud and the ureter extension and subsequent kidney formation that happens. All of this typically starts around the 6 weeks of life is when your kidney development, 5 weeks of life is when kidney development starts, and around 6 to 9 weeks is when the first glomeruli are formed. And CAKUT can happen at various forms of this development. Right in the beginning, you might have renal agenesis. Over the subsequent periods, kidney hypoplasia can occur at any period of time. Ectopic kidney vesicoureteral reflux or a decrease in nephron number can happen throughout 8 to 36 weeks of pregnancy. Typically, valves develop around the 8 to 10 weeks of gestation. That's when the urethra and bladder are formed. But this cartoon here highlights the various stages when these developmental anomalies may occur. So just to recap some of the basics of neonatal nephrology, as I said earlier, kidney development starts at 5 weeks of gestation, and in 6 to 9 weeks, the first glomeruli are formed. All of this typically ends around week 36 of gestation. And we consider the kidneys to have about 1 million glomeruli in each kidney, or 10 lakh glomeruli in each kidney. The bladder is detectable by week 9, and fetal urine is what contributes to amniotic fluid. Most of it, 90% of amniotic fluid is fetal urine. And postnatally, most infants, 90% of them will pass urine within 24 hours of life. So what is CAKUT? Congenital anomalies of kidneys and urinary tract. They can be seen in up to 1 in 500 fetal ultrasound exams, and they typically represent 20 to 30% of all kinds of anomalies identified antenatally. About half of childhood kidney failure worldwide is presumed secondary to CAKUT. Neonatal chronic kidney disease or neonatal kidney failure can be seen in 1 in 10,000 live births. And about, again, progression to end-stage kidney disease is in 7 per 1 million infants aged 0 to 2 years of life, of which lower urinary tract obstruction is the most common cause. Throughout my presentation, you will see these QR codes. They will take you to the article mentioned on that slide. So you should be able to scan it with your phone and see the article. So lower urinary tract obstruction is the most common cause, and of which, again, posterior urethral valves is the most common cause of end-stage kidney disease. So when it comes to lower urinary tract obstruction, we've all heard of Potter's sequence, where a urinary tract obstruction leads to either oligo or anhydramnios and subsequent pulmonary hypoplasia, anatomic deformities, and contractures in the baby. Fetal lung development is heavily influenced by the distension pressure created by fluid around it and the breathing movements, as well as certain other factors, which include growth factors. And this is most critical during week 16 to 26 of gestation, when the lungs are developing, and especially the canalicular stage of lung development, and the basic alveoli gas exchanging units are kind of forming. Now, when a baby with urinary tract obstruction is born, the immediate neonatal outcomes, they depend on the maintenance of amniotic fluid volumes, which would have promoted pulmonary development. So this could be either that the baby only had partial obstruction, or there was a patent urachus and there was still some urine in the amniotic fluid, or some kind of a fetal intervention was done for urinary diversion. So that's kind of the most critical thing which will affect the baby's postnatal outcome. There are certain prenatal findings which can be seen, which are considered typical. The fetus may have dilated posterior urethra, enlarged bladder, and hydronephrosis. So is amniotic fluid volume significant, or does that predict outcomes? This is a very recent study, just came out in pediatric nephrology last week. So this was a retrospective study where they looked at 168 fetuses and they classified them into three groups: normal amniotic fluid or amniotic fluid in the lower normal range, which was called LAF, and then those who had oligohydramnios, which was the ROH group. So what they saw was among these 168 patients who had congenital kidney anomalies, 15% had oligohydramnios. They had 10 babies, or 6% with the low normal range of amniotic fluid, and a large majority, 79%, had normal amniotic fluid. Now, of the 26 families or maternal fetal pairs which were affected by reduced by renal oligohydramnios, more than half of them, 54%, or 14 of them, decided to terminate pregnancy, and there were 10 live-born babies. Of those 10 live-born babies, 6 or 60% survived their observation time postnatally. And of those 6, 5 presented with chronic kidney disease of varying stages. As you can see, most of them had stage 1 or stage 2 chronic kidney disease, but 2 babies ultimately went on to develop more advanced kidney disease, again, during the phase of when this study was done. The main difference, what they saw in the renal oligohydramnios and the normal or low groups were that patients had restricted height and weight gain, they had respiratory issues, they had complicated feeding, and there was extrarenal malformations seen in those with renal oligohydramnios. So their conclusion was that prenatal diagnosis of renal oligohydramnios was associated with elevated mortality compared to other groups of patients with CAKUT. Now, interestingly, if we look at the more details of their postnatal findings, this is again, the QR code will lead you to the paper. And this table is from the paper where they discuss what kinds of congenital malformations were seen in the kidney. There was solitary functioning kidney, a duplex kidney, ectopic kidney. 9 patients overall in the low and normal amniotic fluid group had VUR and hydronephrosis. Low urinary tract obstruction was seen in 3 babies, of which 2 underwent termination of pregnancy, and some were born, a significant number were born with either low or even normal amniotic fluid here. And then they had some babies with ARPKD, ADPKD, or renal agenesis as well. So that kind of brings me to the next point of fetal interventions, which I had mentioned earlier, that sometimes those are done. So these are primarily done to promote lung growth. Various kinds of interventions have been looked at. Vesicocentesis, which is primarily just tapping the bladder of the fetus to mostly from a diagnostic perspective. There can be vesicoamniotic shunting, fetal cystoscopies, again, looking at the fetal bladder for diagnosis, and serial amnio infusions. Folks have looked at fetal urinary biochemical profiles, but the evidence on them is somewhat mixed. There was a recent meta-analysis by Morris and colleagues where they noted that the presence of sodium and calcium more than 95th centile for gestational age was predictive of poor function. Now, fetal interventions are typically done in patients who have severe lower urinary tract obstruction with abnormal amniotic fluid volumes, because 90% of them are likely to die without any kind of intervention, and the progression to end-stage kidney disease is very high in those that survive. This is definitely associated with a lot of risks, both for the mother and for the fetus. There could be risk of preterm delivery, a premature prolonged rupture of membranes or PPROM. There can be amniotic fluid leak, injury to the fetus, even intrauterine fetal demise. And certainly these are not universally available. Even in a country like the United States, this is done in very few centers across the country. So not all places have access to these. Now, interestingly, while I was trying to put together this talk, I found this one paper from a center in Malappuram, Kerala, where they looked at diagnostic amnio infusions at two centers in Malappuram from 2009 to 2016. There were a total of 61 pregnancies between 17 to 26 weeks of gestational age who had either severe oligohydramnios or anhydramnios. And they were doing diagnostic amnio infusion to get better images of the fetus to be able to diagnose what the underlying abnormality or malformation was. And they had, of the 61 fetuses, 19 of them had isolated renal abnormalities, and 17 had renal abnormalities associated with other system malformations as well. And a few had either placental IUGR, or they had an occult rupture of membrane that was leading to low amniotic fluid. A significant proportion of these patients opted for either termination of pregnancy, or they had some other complications at birth or in the perinatal period. So outcomes were not particularly good in this situation. Some of you may have heard of the RAFT study, or renal anhydramnios fetal therapy trial. So this is a study that is going on in the United States in 9 North American sites. And the study involves doing serial amnio infusions for bilateral renal agenesis. So these are fetuses with confirmed isolated bilateral renal agenesis and who received a therapeutic amnio infusion prior to first infusion prior to 26 weeks of gestational age, and they all had normal genetic testing. So 20 maternal fetal pairs underwent serial amnio infusions, and of those, 18 of those 20 had live births at a median gestational age of 32 weeks. There were a few obstetric complications seen. The study had an outcome of survival to 14 days, which 14 of the 18 babies did, and they had a dialysis access placed at that time. Unfortunately, only 5 of 14 patients survived to discharge, and they were discharged on peritoneal dialysis at a median age of about 25 weeks postnatally. Again, 2 of those 5 babies who were discharged died shortly after discharge, and 3 of the 5 infants who were discharged sustained strokes. So this study, particularly this study has 2 arms. They were looking at bilateral renal agenesis, and they're looking at other severe CAKUT excluding bilateral renal agenesis. So the bilateral renal agenesis arm has been suspended after the Data Safety Monitoring Board reviewed the information about neonatal morbidity and survival. They felt like this was not something that was improving the outcomes, and they are no longer enrolling patients for agenesis. They are, however, still looking at patients with severe CAKUT, and hopefully those results will be coming out soon. Once again, the QR code gives you access to the, this was available just as an abstract form currently. The paper has not been published yet, but you should be able to read the abstract with the QR code. So when it comes to management of these babies, there's a lot of prenatal counseling that is needed if the diagnosis is made prenatally. And this prenatal counseling has to be very extensive and multidisciplinary, involving neonatology, nephrology, urology, probably even social work, psychology, all services should be there to provide a comprehensive picture. There can be a really wide range of postnatal presentation. You can have relatively normal kidney function and slower progression of chronic kidney disease to somebody who might need renal replacement therapy pretty much immediately after birth. In addition, there might also be situations where, depending on how the local practices, neonatal dialysis might not even be offered or would be considered futile. So all of those things have to be discussed with the family. If fetal interventions are considered, if those are available, and once again, I'll put the caveat here that they are not available in all centers. For example, the center where I practice, we do not do fetal interventions. So, but if those are available, then again, the concurrent medical diagnosis, other genetic anomalies should be reviewed. The family should also have understanding that fetal interventions do not guarantee pulmonary survivorship or adequate kidney function. And of course, discussing the other risks that may be associated with it. These babies might also require future urologic interventions, which again, might have a wide range. It might be just bladder catheterization or valve ablation, but it can also range to needing urinary diversion and either a vesicostomy, ureterostomy, or nephrostomy. And then there could be need for neonatal dialysis and transition to long-term dialysis. So as I said, psychology, social work, palliative care perhaps should all be involved in these situations. There was a study done by Dr. Sanderson and colleagues. This was a survey done in North America at 39 centers. And they asked centers about what their practices were around prenatal consultations for CAKUT. So 23 out of 38 centers responded that they had availability to use, to provide, all centers, 38 centers had availability to provide some kind of dialysis, and 23 out of 38 centers would use either hemodialysis or continuous renal replacement therapy or prolonged intermittent renal replacement therapy as a bridge to peritoneal dialysis. But of all the centers that were surveyed, more than 50% of them reported contraindications, of which the most common one was the parent or guardian choosing not to pursue dialysis. Another 21 or 55% said they had a birth weight minimum criteria for not performing dialysis. And interestingly, of those centers, 11 said their cutoff was 1,500 grams or 1.5 kilos. And another 4 centers said their cutoff was 1,000 grams. Significant number of or proportion of the respondents also said that if the surgeon indicated there was a contraindication to dialysis access placement, that would be considered a contraindication. some of the features which were not considered contraindication in any of the centers was the presence of conditions like ARPKD or antenatal oliguria, anuria, or any kind of social inequities that would limit the family's ability. So none of those were considered contraindications, but primarily the family's decision and the surgeon's ability to put in a dialysis access, those were considered the two big factors in terms of being a contraindication for dialysis. So moving on to postnatal management of these babies, infants with lower urinary tract obstruction and other severe forms of CAKUT, those who have oligo or hydramnios, ideally, if possible, they should be delivered at an advanced level center where appropriate ventilatory support can be provided. But rest of the management depends on their pulmonary development and additional congenital anomalies. Somebody who has mild lung and kidney involvement may only require a short NICU stay and may be able to be managed outpatient subsequently. Those who are oliguric, anuric, they will require more complicated management. And usually it starts with fluid restricting them until a decision for renal replacement therapy can be made. Enteral nutrition with human milk is preferred, and those who have do not have any kind of cardiovascular compromise, they can safely receive human milk. If that's not possible, then again, these neonates might require parenteral nutrition. Those who have any kind of urologic abnormalities, especially like somebody with a known lower urinary tract obstruction, that obstruction should be relieved as soon as possible. And initially that might be with just the help of a bladder catheter or perhaps even a suprapubic tube until the baby can be taken to the operating room for valve ablation. So initially, the catheter is placed, and again, sometimes the urethral anatomy is complex that a Foley or a balloon catheter might not be able to be placed, so they might require a non-balloon catheter like a feeding tube temporarily that is able to relieve obstruction. The urethra, posterior urethra is almost always dilated. The bladder neck can be high, all of which make the positioning of the catheter challenging. So that might be a situation when the urologist might prefer doing a suprapubic tube placement, or that would be required. Once that is done, at a subsequent time, cystography followed by an appropriate surgical intervention, which again, based on the anatomy, might be just resection of the urethral valve, or depending on how complicated the situation is, they might require a vesicostomy there. Occasionally, when just bladder obstruction relief does not reduce upper tract dilation, or the upper tract remains obstructed, gets infected, we've had patients who have needed a percutaneous nephrostomy or a cutaneous ureterostomy in those situations. Almost always these neonates should be on a prophylactic antibiotic to prevent urinary tract infections. Now, when it comes to renal replacement therapy, before we embark on providing that, there are a lot of questions to consider, and some of those are, can you provide dialysis or renal replacement therapy? What are the outcomes of these children who receive therapy, and how do we provide RRT in a safe manner? So when it comes to providing renal replacement therapy, can you provide renal replacement therapy? If it's a question of technical expertise, I would say yes. In these days, in most centers across the world, some form of initial renal replacement therapy may be provided, whether it's peritoneal dialysis, which is the most common form. And of the available modalities, hemodialysis, peritoneal dialysis, CRRT, which one is chosen often comes down to factors, patient-related factors, center-related factors, and what are the goals that we are trying to achieve. So neither one therapy is better than the other. It all comes down to what is available and what can be provided in that moment for the patient. And hemodialysis is not something that is commonly done. But again, if that were the only option available, and if the physicians felt like that was going to benefit the baby, then there would be nothing wrong in providing hemodialysis as long as it can be safely done. Now, the other question is, should you provide renal replacement therapy? And here, again, is it medically necessary? Does this baby have a condition that can be managed with dialysis? The typical indications are when there is impending harm from the inability of the kidney to do its job. So whether that's failure of optimal medical management, severe electrolyte abnormalities, symptomatic uremia, pathologic fluid overload, those are all indications for doing dialysis. The other question can be one of ethics, right? Now, I am not an ethicist, but I have a wonderful colleague, Aaron Whiteman, who is an ethicist and who I have learned a lot from in this about this. When it comes to ethics, there are a lot of different ways to think about it. There's the best interest standard, which usually requires the parents and clinicians to weigh the net benefits and burdens of a potential treatment option. That kind of serves as a positive principle that if something is in the best interest of the child, perhaps we should be considering it. On the other side, there's the harm principle, which is typically used in the setting of treatment refusals. Is this treatment or the lack of this treatment going to cause harm to the baby or to the patient? There are other things to keep in mind as well. Autonomy, which is challenging in this situation because the patient is not in a position to make any kind of decision here. We think about justice. We also think about what is the relational potential standard. So what is the value of that caring relationship between the parent and the child beyond just the individual interests of either of those? So a lot of these factors might play into a role here. So that's all to say that it is complicated. And once again, Aaron has done a lot of work with Priya Pais from St. John's, and both of these QR codes lead to a couple of papers that Priya has been involved in. And it kind of comes down to a shared decision-making with parents, with the multidisciplinary team. At the same time, decision depends on what is available. There are significant disparities across the world. There are significant disparities within countries like the US and Canada also. So these are all very local, more narrow regional decisions. What is available, what is not available. And this was a line that I read in one of Dr. Pais's papers where it said, even when dialysis is free, it has catastrophic indirect costs. So these might be families who have to move to a different city, different location where their child can get dialysis. They might have economic costs from loss of employment, and other factors are involved. And once again, the same things both Dr. Chanchlani and I see in our practice, where we have patients who sometimes have to move from smaller towns to come and live in big cities so that their children can get dialysis. So these are very complicated decisions, and one needs to think very carefully about all of these factors. So, when it comes to making the decision for dialysis, that shared decision-making looks into birth weight, gestation of the baby, some of the medical factors that they look into are what's the lung status of the baby, what comorbidities are there. And one example here is like CAKUT tends to do better than ARPKD because ARPKD may often be associated with lung or liver involvement. And then support and commitment of the family and the medical team, all of which can play a role in helping make that decision. So what are the outcomes of babies who receive renal replacement therapy? When it comes to acute kidney injury, we know that the outcomes have somewhat improved. Pre-2010, the survival was somewhere between 25 to 45% for neonates who were receiving some form of dialysis, either peritoneal dialysis or a continuous renal replacement therapy. Post-2010, there has been some improvement, and the survival is now 40 to 60%. And sometimes some of these studies might include some neonates who had congenital kidney failure, but were not immediately apparent, or who started out as AKI and then progressed to end-stage kidney disease. For example, one of the cases I showed earlier with MCDK, who had renal artery thrombosis in the solitary functioning kidney. That baby started out dialysis as an acute kidney injury, but then never recovered and progressed to end-stage kidney disease. When it comes to patients who have congenital kidney failure, the survival outcomes are more long-term, and most studies that have looked at these patients have reported somewhere between 75 to 80% 1 year or 5-year survival. Now, the caveat here is that most of these are registry-based data. So often patients who survive the initial neonatal hospital stay and go on to get discharged are the ones that are entered into the registry. So there is some skewing of data there, but it's still fairly good outcomes. This was a paper published last year by Donna Clays and colleagues. This was a retrospective observational study of something called the Pediatric Health Information System database. And this is a database of hospitals in the United States. And they looked at 39 hospitals from 2005 to 2019. And there were 213 neonates who were born with kidney failure during that time in the hospital. So of those 213 neonates, the median gestational age was 35 weeks and the birth weight was 2.7 kilos. And the 24% of them died by hospital discharge, which is a 76% survival to hospital discharge. 98% of those babies received renal replacement therapy for a median of 63 days, so about 2 months in the hospital. Most of them received peritoneal dialysis only, but then some received PD plus some other form of extracorporeal renal replacement therapy. And what they saw was the predictors of increased mortality included longer duration of mechanical ventilation, plus the requirement of an extracorporeal form of dialysis in addition to peritoneal dialysis. Because again, one can kind of understand that somebody who may be relatively stable and can go to the OR and get a PD catheter placed and maybe wait for the PD catheter to heal, that patient is likely to probably have a better outcome than somebody who is so critically ill that they are not able to have a PD catheter placed and need to go on some other kind of dialysis for a while before starting a PD might have a poorer outcome. Other studies have also shown that outcomes are improving. So these are two graphs from the NAPROTICS database, or the North American Pediatric Renal Trials Collaborative Studies Network. So when they look at the 1992 to 1999 cohort, this red line depicts those who started dialysis between 0 to 365 days of life, so 0 to 1 year of life. And you can see how the red line is very far away from all the other lines which represent the older patients. However, between 2000 to 2012, the red line is somewhat closer to the other patients. So the survival for babies who were starting dialysis in the first year of life is now almost similar to those who start dialysis later on beyond first year of life. More recently, there was this one study from Scott Sutherland and colleagues from Stanford, where they looked at 7 preterm low birth weight neonates. 6 of these babies had CAKUT. The median gestational age was 32 weeks, birth weight was 1.58 kilos, and all of these babies received dialysis using a device called Aquadex. They received prolonged intermittent renal replacement therapy. And 5 out of 7 of these preterm babies, again, survived to hospital discharge. And 4 went on to doing peritoneal dialysis as a bridge to transplant. And 1 was on hemodialysis. Now, if we look at more details of these patients, you'll see here highlighted the kind of respiratory support they were receiving at initiation. And most of them were either on a on relatively low respiratory requirements. So they were either on a low flow nasal cannula or just SIMV ventilation, or there was 1 patient on room air, 1 patient on CPAP. And by the end of 1 week, only 1 patient was still requiring invasive ventilation. The others were either on just CPAP or room air. So it kind of brings it back to the fact that in the initial period, it's the pulmonary development that will determine what their outcome is likely to be. Now, renal replacement therapy in neonates has its own unique challenges because we used to have limited outcome data, which is now somewhat getting better. The devices that we have, they were designed for adults and older children, so they often require larger catheters. They have high extracorporeal volumes, and then we don't really have protocols or guidelines designed for neonates. So when it comes to options, once again, you saw this slide earlier, any of the options might work depending on what's available and what the baby needs. So let's just discuss a few of these briefly. When it comes to peritoneal dialysis versus other forms of extracorporeal renal replacement therapy, PD is cheaper, easier. Ideally, the catheter should not be used for a while, but it can be used immediately. You have some relative control of ultrafiltration, though not super close control. Extracorporeal therapies are obviously more expensive. They require more training, but they do provide you more tighter control, and you can use the catheter immediately. And somebody who has GI or lung issues, there's no fluid in the abdomen, so that tends to help a lot. What's important to keep in mind are that these modalities are complementary. It's not, again, a question of one versus the other, but sometimes patients may require both forms of therapy before they can be finally stable. Basic principles of peritoneal dialysis, there's sterile dialysate, which is introduced into the peritoneal cavity through the catheter. The solutes are removed by diffusion and fluid is removed by ultrafiltration. And PD is the most common chronic dialysis modality, both in the US and worldwide, particularly for infants less than 1 year of age. The ISPD, or International Society for Peritoneal Dialysis, their guidelines recommend waiting at least 2 weeks after catheter placement to start PD. However, the SCOPE Collaborative, which is the Standardizing Care to Improve Outcomes in Pediatric End-Stage Kidney Disease, reported that about 1/3 of catheters are used within 14 days of PD catheter placement. Similarly, IPPN, which is International Pediatric Peritoneal Dialysis Network, they reported that 46% of catheters were used within 7 days of placement. Now, using a catheter sooner than 14 days is associated with a higher risk of peritonitis or catheter leakage or mechanical failure. But sometimes that might be the only option that the patient has. So it may need to be used earlier than 14 days. This is what a typical sample PD prescription would look like. Often they are starting out with manual cycles with low fill volumes of 10 mLs per kg. And sometimes heparin is added to the new catheters, especially if there is some fibrin seen. And then the dextrose concentration is what will drive our fluid removal. So that can vary from 1.5, 2.5 to 4.25%. Hemodialysis is highly efficient, but it is more challenging to do in a small neonate and requires more resources. Accomplishing fluid management for a neonate in 3 to 4 hours can be challenging because they might not tolerate the volume shifts. And then often they might require daily blood prime, which can have implications for transplant. So this is where either continuous renal replacement therapy or prolonged intermittent renal replacement therapy comes in, which can be a slower, steadier form of providing dialysis with less hemodynamic stability, slightly more physiologic, perhaps kind of like peritoneal dialysis. The disadvantage is, again, the cost, resources, and the need for more trained staff. So I think I showed that slide earlier. This shows you some of the devices that are available or are being trialed across the world. So PrismaFlex or Prismax are the common CRRT machines. There's Carpe Diem, which is a neonatal specific device. Nidus is being is undergoing studies in the United Kingdom. It is not available commercially currently. And then there is Aquadex, which is an adapted device. So PrismaFlex or Prismax, I'll just go over these very briefly. They have a smaller filter, which had been available across the world for many years and is now recently become available in the US. So when I say approved, that is just based on the US FDA approval for 8 to 20 kilos, but other places might have different regulatory guidelines for it. It has an extracorporeal volume of 60 ml and is really good in neonates who require higher clearance for ammonia or when smaller devices are not available. Aquadex was designed for ultrafiltration only. The idea behind the machine is that a patient is connected, and there's an anticoagulated circuit, and it just removes extra fluid from those who have congestive heart failure. That's how the machine was designed, and the blood goes back into the patient. And then Dr. David Askenazi, they decided to modify it by adding some convective clearance and adding some replacement fluid to provide dialysis for neonates. Now, the thing is, the device is not meant to provide dialysis or convective clearance. So this step here of the replacement fluid, that requires a separate infusion pump. And these do not communicate with each other. So that can be sometimes a little bit challenging in the sense that if one machine stops, you have to be very cognizant of the other machine and making sure that is not working, and that is also stopped as well. And then they both have their own errors, which can add up to a significant fluid discrepancy in a small neonate. These devices have been used fairly extensively now between a case series and an abstract. About 129 patients ranging from 1.4 to 9.7 kilo weight used it. Of those 129 patients, 19 of them had neonatal end-stage kidney disease or congenital kidney failure, and many of them were able to use it with a smaller 6 French catheter. Now, if you look at the duration of treatment, overall was 9 days, but patients who had congenital kidney failure, they received treatment for many, many months before they could be transitioned to another form of outpatient dialysis. Carpe Diem is one of the newer devices designed for neonates and infants. The weight ranges from 2.5 to 10 kilos, and it can work with a blood flow of 2 to 50 mLs per minute, which is exciting because that means it's a smaller device. You can use a smaller catheter there. So once again, this has been used, has a fair bit of experience now with all of these devices, and the outcomes seem to be fairly good. But not all of these devices would be available anywhere, everywhere. So you have to be good at what is available and what you can work on. So why do we need pediatric or neonatal specific devices? Because those devices can work with lower blood flow, smaller extracorporeal volume. They are more accurate, which are all good for the babies. Dr. Ganeshan, how am I doing for time?
It's all right. You're allowed till 7:40 to our time. You still have 13 minutes to go.
Okay.
All right.
Thank you. So yeah, so why do we need smaller devices? Because we can, babies are small. We require smaller catheters. We are trying to avoid blood prime in these babies, and we want more accurate devices. So let's look at what these devices are and what the blood flows are. So this table here tries to summarize the available devices, and you can see, depending on whether it's a neonate specific device or an adapted device, the blood flow can range anywhere from a lower end of 2 mLs per minute or 5 mLs per minute for NIDUS, all the way up to 200 mLs, 50 to 200 mLs per minute for an M60 filter. So that has implications on what kind of catheter can be placed in a baby. This here, neonates can come in different sizes, from a very tiny preterm baby all the way to a bigger term baby. And their internal jugular vein can vary in size as well. So if we look at, the suggested catheter to vein ratio is supposed to be less than 33 to 45% here. So these are the available catheters in the United States. Perhaps some of you have different catheters available. I feel like sometimes things come more slowly to the United States because of all the regulatory requirements. But the smallest dialysis catheter we have is a 7 French line, and the newer adapted double lumen catheter is a 6 French line, which is 2 millimeter. So if we go back to our the common neonate size, the neonate between 2 to 3 kilo weight has a internal jugular vein of 3 to 4 millimeter. So sometimes these catheters can be a little bit challenging to put in those situations. So a 6 French line in a 3 millimeter blood vessel is just barely acceptable. Ideally, you would want a 3.5 millimeter sized blood vessel for that catheter to sit there appropriately without causing any obstruction. So that can be sometimes a challenge. Then we need, again, we talked about the blood prime requirement. So going back to this table again, the extracorporeal volume of various devices can range from less than 17 mLs for NIDUS, which is not yet commercially available, all the way up to 93 mLs for an M60 filter, or 60 mLs for an HF20 filter. So if we put that in context for a baby, these are all the available filters and their extracorporeal volumes. So for a 4 kilo baby, if you are using something like an HF1000 filter, 52% of this baby's blood volume can be in the extracorporeal circuit. Whereas if you have a filter that is 30 to 40 ml, that might only be 10% of the extracorporeal volume. And obviously, if the baby is smaller than 4 kilos, that number then varies is even more significant. So that has implications, because if your extracorporeal volume is larger than 10 to 15% of blood volume, you might require to do a blood prime for that patient. And there are some risks associated with blood prime because packed red blood cells from the blood bank, they have very low calcium, they have high citrate, they have high potassium, low pH, and all of those things can be somewhat tricky when a baby is starting dialysis. And they also lack platelets and coagulation factors. So the larger the blood prime, the more dilute your platelets or coagulation factors can be, and they can all cause some instability in the baby at the start of dialysis. In our program, this is what we use as a guideline for blood prime. So if it's more than 15%, we will definitely do a blood prime. Less than 10%, we will not do a blood prime. And between 10 to 15%, we think about how hemodynamically stable or unstable the patient is. Are they a future transplant candidates? Do they have end-stage kidney disease? Are we trying to avoid blood exposure here? And then finally, there is accuracy of ultrafiltration. Once again, going back to this table, most of these machines designed for adults have a 10%, plus minus 10% accuracy, which can be significant for neonates. The two machines, one which is available for neonates and one which is in the works, designed for neonates, both of them have have a narrower or tighter ranges of ultrafiltration. So I'm going to skip this part. All right. So when it comes to providing renal replacement therapy safely, what is important is to have a team of people, whether that should include nephrology, neonatology, nursing. It should include pharmacy, nutrition, who is going to be your vascular access provider, who is adjusting the medications for these patients. Make sure you have policies and procedures in place so you're doing the same thing every time. You're not changing your protocols based on who is the physician who is supervising it, or what kind of situation is going on. Check your data and review it periodically. Give feedback if there are things that are done differently or there are adverse outcomes. And then additional management of the baby with severe kidney failure or neonatal kidney failure beyond renal replacement therapy involves optimal nutrition. Many of these babies might require tube feeding, whether that's an NG tube feeding or a gastrostomy tube feeding. If we are going down the gastrostomy tube route, ideally the G tube should be placed either at or before the PD catheter placement. The risk of infection is lower with that, though that may not always be possible. They need appropriate salt and sodium and fluid management. When I was a fellow, one of my attendings used to say you need to salt and water the baby, especially with CAKUT, because they might be losing a lot of sodium in their urine. They might require some kind of bladder management long-term, whether that's clean intermittent catheterization or some kind of diversion temporarily until they can go on to clean intermittent catheterization. And definitely other optimization around CKD, management of their anemia, bone disease. And all of this leads to our ultimate goal of preparing them for a transplant. And while the centers might have different criteria, typically it's around 10 kilo weight, 75 to 80 centimeters length is what most need to achieve to get to transplant. So to summarize, severe CAKUT can lead to chronic kidney disease and end-stage kidney disease. Immediate postnatal outcomes are dependent on pulmonary development. Renal replacement therapy can be provided to very small, critically ill babies, and the choice depends on various factors. Neither modality is better than the other. And long-term outcomes for those who start dialysis are improving over time. Fetal interventions are being increasingly attempted, but we don't really have a lot of data on their impact or their outcomes. There are a lot of global disparities in the availability of various therapies, and as a result, there are lots of ethical dilemmas around this issue. And it is important to have multidisciplinary teams taking care of these patients: nephrology, neonatology, nutrition, social work, pharmacy, palliative care, urology, surgery, psychology. It takes a village to help support babies with severe CAKUT and congenital kidney failure. And with that, I am happy to take any questions now.
Thank you, Dr. Menon, for an exciting, excellent, and a comprehensive talk on CAKUT. So I will open the panel for questions. There's already one question in the chat box. They say, what is your PD catheter for very low birth weight children? Is it, I don't know whether they're asking size, or I don't know, but maybe we can try answering this question.
Yeah, so it's a very good question. At our center, often very low birth weight babies, unfortunately, our surgeons will not put in a PD catheter until we can grow them a little bit and we can get them slightly bigger. So it might vary from like who's placing the catheter. And sometimes very small low birth weight babies, they might require temporary catheters, not necessarily a proper PD catheter, but if you're trying to provide clearance, Dr. McCullough has published papers on using alternative catheters. Even feeding tubes have been used in those situations, because those might be the only ones that actually fit in the abdomen and can be used.
Thank you, Dr. Menon. Any other questions from anyone?
Yeah, well, I think I can continue with the discussion that we have here. And I can say, at our center, usually our surgeons are about like 1,800 grammars. They would put in a PD catheter. And I would love to, hear from Rahul, you, and then China, what size of catheter, or like now I should say, what weight of the child your surgeons have.
I mean, they can put, PD catheter. I think the major problem is that how long would that catheter last? What will be the complications of that catheter? And the other thing would be, how would you sustain the child? Because the machines that we have, the Baxter machine we all use, I think the minimum volume is what, 120 ml, right? Before the child goes on the machine. So I think those are the other issues that we are also facing, right? Go ahead,
Yeah.
Shanna.
Yeah, I totally agree. So, putting in a catheter is, I think, one of the easier parts, but it's the challenges of maintaining that catheter and preventing leak. And given that many of these babies are now surviving beyond the neonatal period, so we've kind of made that decision of not putting in a catheter until we know that catheter can be kept in place for 2 weeks before using it. So we try to optimize the conditions before placing a catheter now.
Great. There's another question. Are umbilical lines used for access?
Some centers have used umbilical lines for vascular access. Usually, again, we reported in our center has not used them, but I know colleagues who have used them. They will typically use 2 single lumen catheters, so a 3 French and a 4 French, or a 4 French and a 5 French. And in that situation, one of those can be an umbilical line.
Okay. Another question, how early will you perform MCUG, which is VCUG, for a newborn with suspected PUV?
For us, it's often like if they are admitted, like if they are born and we know they had PUV antenatally, they will be taken by the urologist for a cystoscopy, and then they'll do urethrogram with the cystoscopy, and that might be in the first 2 to 3 days of life, depending on if they have to stabilize the baby for other things.
Thank you.
But for valves, definitely it's something that's done at a fairly early phase.
Okay. Another question, how frequently the filter needs to be replaced in CRRT?
That might depend on what kind of machine you are using. For example, Carpe Diem requires the filter to be changed every 24 hours, and you cannot bypass that. You have to change it at every 24 hours. Aquadex requires the filter to be changed at every 72 hours. Once again, that cannot be bypassed and has to be changed. For a Prismaflex, which is the third device that I am familiar with, technically, the recommendation is to change the filter every 72 hours. But at our center, we change it at every 7 days. If it's lasting, if it continues, we just let it go for 7 days and then change it.
Interesting.
The issue we encounter with not changing the filter after 3 days is cell trapping.
Yeah, we have not seen that for with the filters. When you say cell trapping, you mean do you start seeing hemolysis and or like clots forming?
There is a drop in platelet count as well.
Oh, okay. Yeah, usually like if we start seeing clots building up, then we'll change it. But if it's going fine and there are no complications, we've let it go for 7 days.
Okay, even with the HF20 filter?
Yeah, HF20, sometimes it doesn't last beyond 72 hours, but I was actually looking at some of our data just yesterday for one patient where it went for 150 hours and it was changed at that time. So.
All right, one more question. How long can we wait on CRRT for results? I don't know what results mean, maybe improvement in biochemistry or urine output, I don't know.
If I don't know if they want to clarify their question. So if it's biochemistry, that will probably improve in a few hours to 1 day fairly rapidly. If we are thinking of overall kidney function, most of these babies, we anticipate them to have chronic kidney disease. So I would not expect much of an improvement just because they are on CRRT. They will probably require to transition to peritoneal dialysis ultimately.
That's right. I have another question. So for these, going back to PD, because I know some of the participants here are from countries where we may not have CRRT services. So going back to the machine, so are you aware of any manufacturer who is trying to make machines with lower volumes? Like, we can transition them earlier to the machine rather than going for the manual dialysis?
Unfortunately, no. We try the cycler sometimes at 90 mLs, and that seems to work. But yeah, no manufacturer is working on this because it all comes down to money, and they do not find it financially viable. I mean, all their financial interests are in taking care of adults, so. This is not something that anyone's willing to spend time and money on. That's just an unfortunate pediatric situation. The same holds true for catheters also, both PD catheters and dialysis catheters. We often have various kinds of shortages. Sometimes a 7 French is not available, sometimes 8 French is not available. Sometimes 7.5 French is not available. So that becomes a challenge. And with PD catheters, most recently, I think CAKUT stopped manufacturing some of their PD catheters. So that has been, and that was exclusively used, I think, in pediatric acute PD. So it's, it's just a sad situation.
Any other question? Dr. Jain, Dr. Ganesan, should we wrap up the session then?
Now, Malva sir, do you have any questions? So you have muted, sir. You have muted. Can you unmute?
My days are not known for CRRT and other parameters. We all depended on hemodialysis at the most, and when for peritoneal dialysis. We used to use sometimes the venous vein IV catheters, small catheters, they're long and they have one hole, and then snip off the top towards it just to make an additional hole and use it for peritoneal dialysis for newborn children who are very small, and catheters cannot be used. And we used to we used to do the same catheter again. The intermittent catheters will not be available. So we used to, after one child is over, we'll keep it in a lotion and then wash it and sterilize it and then use it again. But now there's a lot of luxury in using dialysis catheters and whatnot. So these are new to me, and I learned a lot from Dr. Shainaman today. Of course, I could not remember everything, but I knew there's such an advance, which probably, it's something which takes a long time to understand. Thank you very much, Dr. Shainaman. It was so wonderful lecture, and to be honest with you, I learned so much today. Thank you very much.
Thank you. Thank you for saying that.
Thank you, Dr. Namalwar. Thank you, Dr. Menon. Thanks for being here. Thanks, everyone, for listening and attending. And over to you, Dr. Jain and Dr. Ganesan.
Yeah, thank you so much, Dr. Rahul, for your session, and we really appreciate that. I know you have to leave on time, so thank you again for joining and for your excellent moderation. We can go ahead with the next part of the ceremony, Dr. Kalavani.
Thank you, Dr. Sheena. Like if you are willing to stay back, it's still okay with us. Namalwar sir, we request you to kindly stay back for the session because we have the polling session winners. Yeah.
No
Sheena, it was really an enlightening talk. It was great talking to you.
Yeah, thank you so much, Shaina. I know you are the expert in neonatal CRRT at this point in time, and we are really happy that you could join and share your knowledge with us. We really appreciate that.
Yeah, thanks for inviting me. I'll stay for the award winners.
Yeah, thank you so much. That's nice of you. So we had totally 11 webinar sessions and we had polling sessions. We had total 9 polling sessions, and the cumulative marks were taken into for consideration for the scoring. And so the first prize was Dr. Jiba. She is a third year MD nephrology from Chennai, graduated from Madras Medical Mission. And the second prize is Dr. Prashant, who's also a DM nephrology, doing her second year from GMKMCH Salem. And the third winner is also from the same medical college, and he is Dr. Chakravarti, who's doing his DM nephrology second year. Congratulations to all the winners, and they have a cash reward of 15,000 INR, 10,000 INR, and 7,500 INR along with the winning certificates. Thank you so much. Does the winners want to share any experience of participating in this webinar series? Dr. Jiba, you are there?
Yes, ma'am. Thank you. So it has been a very enriching academic experience in the last few weeks. I really thank the organizers for meticulously selecting these topics and bringing such excellent speakers. So basically, I'm not a pediatrician. So though we get to see children after 13 years, most of the time they reach end-stage renal disease. They are referred to us for transplant or for dialysis. So these talks have basically given a fair idea about how these diseases start, how they present. It's completely different from how it is in adults. So definitely these talks have helped me understand these diseases better. And I really want to thank Thangavelu sir, because I had actually come for an OPD consultation, and that's when he introduced me to this master class. So I'm definitely thankful to him for introducing me to this. And thank you so much to all the faculties for arranging such wonderful series. Thank you.
Dr. Prashant, you're there? I think Dr. Prashant is not there. Or Dr. Chakravarti, would you like to share a few? Dr. Prashant,
Yes,
would you
madam.
like to?
Yes, ma'am. First of all, I would like to take this opportunity to congratulate my fellow winners, and also thank the organizing committee for having conducted such an extraordinary academic feast where we could learn a lot of things about pediatrics and also listen to eminent speakers from all over the world. And I would like to highlight some of the like key aspects of this webinar. Like first, we got to listen to some of the eminent speakers who were experts in their own field, and also the most important thing was we could get to learn from their clinical experiences, which is not always seen in textbooks. So the clinical experience part, which we could learn from them, was an interesting aspect of this webinar. And third, I would also like to congratulate the organizing team for having conducted the webinar in such a smooth and hindrance-free manner, so that it was a hassle-free experience for all. And yeah, thank you. I'd like to once again thank you, the organizing.
Thank you, Dr. Prashant. Dr. Chakravarti, would you like to share your experience?
Yes, ma'am. Good evening, ma'am. Good evening, one and all. It is very useful for me, and I also did my DCH 2009 to 11 at Madras Medical College. At that time, Sir Tangovel sir was my teacher, and also I attended Dr. Nammalwar sir lectures in many forum, and also I studied Sir Nammarwal sir pediatric nephrology book for preparation and also my career. It is and also this eminent speaker from all over the world gives clinical knowledge about pediatric and neonatal AK and CKD and then CAKUT, and this is very useful for us and for all postgraduate for getting knowledge in pediatric. I thank for all the speakers and also for arranging all the faculties arranging for this webinar, and also I welcome and kindly conduct many CMEs and many conferences like webinars like this. Thank you for all.
Thank you, Dr. Chakravarti. Nammalwar sir, Amrish, would you like to congratulate the winners?
Please go ahead,
Okay, I'm here, no? I mean, I'm so thrilled to see that the DM adult medicine people taking interest in pediatrics and they're sharing their views. I must thank you, Kalaivani, for bringing in a rapport between these two sets of groups of people. I congratulate all the three of you. God bless you and do hell.
Thank you.
Yeah, a very congratulations to all the winners. I think we are very happy that this has been a good learning experience for you. And we would want to make sure that, this continues as a good learning tool for all the postgraduates and all the trainees back in India. But as we know that this has been actually a very international audience, and this has benefited people from Saudi Arabia, from Africa, from other parts in Asia, and definitely in United States. We are really excited that this annual teaching opportunity has been a great learning experience for all the residents, fellows, and trainees. And as Dr. Nammalwar said, that going to the adult nephrology world as well, I think that is really exciting that people from there are also being benefited. So again, congratulations to all the winners. Dr. Kalaivani, you're muted.
Okay, we're not able to hear you, Kalaivani.
Thank you. Yeah, sir. Thank you, Dr. Amrish. Again, I would like to thank all the participants and faculties because they had always been a great support for us. And without like a great participants list, we would not have been successful for the last 4 years. And we had all eminent faculties. Thank you all for joining us and to be part of this webinar. And once again, I would like to thank our administrators and a big thanks to IPNA for helping us share knowledge and keep our academics reaching globally. And to start with, this webinar was started in 2020, which was on clinical nephrology, more of general nephrology topics, which was spanning for 3.5 months. And we had great participants. participants. And 2021, we had symposium, exclusive symposium on pediatric glomerular disease. 2022, we had exclusive symposium on tubular disorders. And this year we had it on CAKUT. Probably if IPNA is going to support for the following years, our plan is to have it as an annual event, and the next year would be concentrating on pediatric chronic kidney disease. And big thanks to Amrish for teaming with us. He has really made this webinar successful. More of work is being done by him this year. Thank you so much, Dr. Amrish, as well. And we have an upcoming physical CME, Dr. Georgie Abraham first annual oration, which is going to be a physical CME, which is going to be held in Chennai at Radisson Blu. And we have an exclusive workshop, which is on June 30th, which is all about peritoneal dialysis. And we all know, like, Dr. Georgie Abraham was the person who has brought in peritoneal dialysis into India. And so we'll be definitely hearing from experts, and he's there as faculty in a few of the lectures to teach us on peritoneal dialysis. I request all the participants, if they are interested, to join for the physical meeting, which is going to be on June 30th at Mehta Hospital, and July 1st and 2nd at Radisson Blu. Once again, I thank all the participants and faculties for making our webinar series and a successful one. Thank you, Dr. Sheena Menon, for sharing all the knowledge. Thank you so very much. It was really an enlightening talk, and it was great listening to neonatal dialysis, which is less commonly done in India. Thank you so much.
Yeah, thank you again for inviting me, and you've organized a great series, so keep it up.
Thank you so much.
Yeah, thank you, everybody. Thank you, Dr. Namalwar. I think you have been a great source of inspiration for us, and you have overseen all the lectures, and you have attended each and every session for us. And we really appreciate all your time and your guiding principles. So thank you so much, sir.
On the contrary, I thank you very much for giving an opportunity. Thank you very much. It's so nice to meet you over the webinar program. I hope I someday can meet you personally.
Yeah, I wish the same, Dr. Namalwar. Thank you so much.
Sir's input has been the fruitful thing for all the webinar sessions. Thank you, Namalwar, sir.
Thank you.
Thank you, sir. Thank you, Amrit. Thank you, Sheena. Thank you, Uma.
Thank you, everyone. Thank you, Dr. Uma. Bye-bye.
Thank you. Bye-bye.
Bye-bye.